students. Today we are going to discuss some case scenarios on the hepatobiliary system. The topic is important from the surgical point of view as well as from the GIT medicine. So let's looking forward towards the scenario. A 30-year-old female having colicky right upper quadrant pain radiating to back with nausea and vomiting has several episodes in the past 3 months. On examination, the abdomen is tender in the right upper quadrant. On laboratory test, her WBC is raised and LFTs were normal. In this scenario, there is a female, there is a middle-aged female, and she has having a right upper quadrant pain which is radiating to back as well as radiating to the back of the scapula. If we add here another point that is towards the back of the scapula, then it will be more fine. She is also complaining of nausea and vomiting, and she has several episodes in the past. So what will be our differential diagnosis? We will rule out the differential diagnosis of the right upper quadrant pain as well as the likely diagnosis of the given scenario. As as the LFTs are normal, but the WBC is raised, as well as the abdomen in the upper quadrant is tender. So let's go towards our differentials. What is the most likely diagnosis? Can you someone guess? What are the differential diagnosis? How will you investigate this patient and how will you treat this patient and what complication he can develop? So, the most likely diagnosis of the right upper quadrant pain, which is radiating towards the back of the scapula, is acute cholecystitis. So, why not acute hepatitis? It can be acute hepatitis, but in acute hepatitis, in the LFTs, ALT will be raised. The enzyme ALT will be raised. Why not acute bacterial cholangitis? In the acute bacterial cholangitis, there will be jaundice. In our scenario, the patient is not giving any history of jaundice, while in acute bacterial cholangitis, there will be a history of mild jaundice. While in acute hepatitis, the liver enzyme, that is the ALT, will be raised. Why not acute pancreatitis? In acute pancreatitis, there is also pain in the epigastric region with nausea and vomiting, but the nature of the pain is very sharp and it is radiating towards back, but the nature is very sharp. Why not perforated duodenal ulcer? In the perforated duodenal ulcer, there are also pain in the epigastric region, sometimes in the upper quadrant region, but there will be signs symptom of acute abdomen, that is there will be gardening and rigidity, so we can easily exclude perforated duodenal ulcer from our likely diagnosis. Why not acute appendicitis? In acute appendicitis, basically pain starts around the umbilicus. First, initially, the pain start around the umbilicus and then it migrate or radiate toward the right iliac fossa. So we can include it in our differential diagnosis on the basis of some sign symptom which resembles to the acute cholecystitis, which are the patient will have vomiting, diarrhea, as well as abdominal tenderness, abdominal pain, but the pain initially will be around the umbilicus, which we can confuse it, due to which we can confuse it with acute cholecystitis, but later on the pain shifts toward the right iliac fossa. Why not acute pyelonephritis? In acute pyelonephritis, the patient will have high grade fever, as well as there will be sign symptom of urinary system, that there will be increased frequency urgency, dysuria, and nocturia like symptoms. And why not right lower lobe pneumonia? In right lower lobe pneumonia, we have pain in the right upper quadrant, but there are a sign symptom of pneumonia, that is productive cough and high grade fever. In our case scenario, these sign symptoms were not given. Now we are going towards our management. In the management, first we will take a detailed history from the patient. In the history, we will ask about the onset of the pain, which will be sudden. The duration will be short. There will be a history that after taking fatty meal, I have developed this pain, and this pain is radiating to the back of my scapula, as well as it will be associated with nausea and vomiting. The patient will be giving history like this, as well as the nature of the pain will be colicky, and the patient will be afebrile. On examination, the Marpi sign will be positive. What is Marpi sign? In Marpi sign, the examiner palpate the right upper quadrant of the patient. During deep palpation, when the patient deeply inspire, he feels pain. On deep expiration, his pain increases by palpating the right upper quadrant of the patient, and mass may be palpable if the omentum, which normally called the policeman of the abdomen, when there is an inflammation of any organ, any abdominal organ, the omentum surround itself around the organ to prevent damage to the other organ. That's why when the omentum gets surrounded from the gallbladder, then a mass will be palpable in the right iliac fossa. For the definitive diagnosis, we will do ultrasound. In ultrasound, a single hyperechoic area will be seen with a black shadow behind. As well as in ultrasound, if the CBD, that is the common bile duct, is dilated, we can differentiate it. After ultrasound, we can do CT scan, but in CT scan, it is not more accurate than ultrasound, and we can know about the serosa, about the empyema, about the anatomical structure of the gallbladder and its related organ. In head scan, we can know about the function of the gallbladder, while at the end we can do MRCP and ERCP, which are invasive endoscopic techniques, in which in ERCP and endoscope is passed through the mouth into the duodenum, and then from the duodenum to the ampulla of Vater, it is passed to the common bile duct, and we see that if there is any stone in the common bile duct, we can remove the stone, we can insert the stent. So, and we can also take biopsy in case of any hepatocellular carcinoma or any cholangiocarcinoma. So this is the last option we can do in the actually we are not going to do it in the acute cholecystitis, but we can do in the, if we are suspecting stone in the CBD common bile duct as well, then we can do ERCP. Now the treatment, we will keep the patient nil by mouth until and will give until his vomiting subside, and will give IV fluid until his pain resolve. We will give analgesic. We will give broad spectrum antibiotic to cover the gram negative aerobe, which are ciprofloxacin, a fluoroquinolone group, cefazolin, and cefuroxime, which are cephalosporin group. When infection resolved, then we ask the patient to come after 1 week for surgery if the cholecystitis is symptomatic. In asymptomatic patient, we sometimes also do surgery if the patient have correlated diseases, comorbidities like diabetes and like sickle cell disease. The surgical option are open cholecystectomy and laparoscopic cholecystectomy. The complication the patient can develop are empyema of the gallbladder. If the stone stuck in the neck of the gallbladder, it will lead to the stasis of the bile within the gallbladder. If the stone stuck here in the neck of the gallbladder, suppose this is the common bile duct. This is the common bile duct. If the stone stuck here in the cystic duct or in the neck of the gallbladder, it will lead to the stasis of the bile within the gallbladder, which leads to distension of the gallbladder, and bacterial infection or suppuration of the fluid can occur, leads to the empyema of the gallbladder. When bacterial infection in the bile occur, it leads to empyema of the gallbladder, as well as due to stasis of the bile in the gallbladder get distended, and pressure on the wall of the gallbladder increases, due to which the blood supply of the gallbladder get compromised and it undergoes some necrotic changes, which is called gangrene of the gallbladder. Due to this tension, it can perforate and lead to acute abdomen, and the stone also get dislodged from the gallbladder and enter into the common bile duct. When the stone enter into common bile duct and obstruct here, we call this condition as the cholelithiasis, and it can lead to acute jaundice, because bilirubin from the liver come to the right and left hepatic duct into the common bile duct. In the common bile duct, when there is a stone, the outflow track for the bilirubin is now blocked, so bilirubin will increase in our body, and it will leads to jaundice, as well as if there is stasis of the bile and the bilirubin in the common bile duct, it will leads to acute bacterial cholangitis, in acute bacterial cholangitis, there will be high grade fever, pain, and the patient will be febrile. Finally, the stone can dislodge and enter the pancreas. In the pancreas, here in the second part of the duodenum, it can enter into the pancreas and stuck in the head and neck, in the neck of the pancreas, can cause acute pancreatitis. This stone can also stuck in the small intestine and lead to gallstone ileus. Thank you so much. If you liked my video and like this scenario, please subscribe the channel and share it, so that I get motivation for making and uploading more videos.